Welcome, everybody. I do realize I am the one person standing in between you and lunch, so we will try to make this as quick as possible. But it's an important topic. I did my initial certification in 2009 and recertified 2 years ago. And there's a big change I noticed. The initial certification was definitely heavily based, a lot of pharmacology. The exam writers love the pharmacokinetics, pharmacology of antiplatelet therapy. So it's an important topic. There's going to be a number of questions on it. And the recertification I noticed was a lot more clinically based. So applying those pharmacologic theories to a clinical vignette is what we're going to need to know for sure. So without further ado, I did this purely all question based. So we'll present the question, you guys scream out an answer or don't answer, however you want to do it. The references are, I go by guidelines. This is a landscape that has changed so much in the past 3 years. You all know this. We're shortening DAPT and all these things, getting rid of aspirin. But the guidelines, the test writers are going to test you on really what's standard, what's guideline driven. And until those guidelines come out, I'm not sure they're going to ask you about, aspirin withdrawal at this point. So without further ado, so which of the following antiplatelet agents interact directly with platelet surface membrane receptors? Clopidogrel, prasugrel, aspirin, vorapaxar, A and B, A, B, and D. Yell it out. Anybody? So A, B, and D. So why is that important? Well, it's important because then when you understand where these agents work, you can understand why pharma companies are targeting them. So by and large, this has a laser pointer. Oh, good. So the P2Y12 receptor antagonists, the ADP site antagonists, work through a platelet receptor, the P2Y12 receptor. The 2B3A receptor is for the large and small molecules. Vorapaxar works through the PAR1 receptor, which is also platelet membrane. Aspirin does not. Aspirin works through intracellular and extracellular cyclooxygenase. So simple question, but if I recall, that was on my initial or a version of it. Okay, all the following are true regarding ticagrelor, except it inhibits cellular uptake of adenosine via the sodium-dependent receptor. It's metabolized to adenosine. It significantly increases coronary blood flow. Adenosine inhibits platelet activation via the A2A and A2BR genes who are upregulated with ischemic injury. There's an increase in serum creatinine in ticagrelor patients compared to clopidogrel in patients in Plato, all the above. So all those are true except for ticagrelor being metabolized to adenosine. This is important. Why do I say that? Well, ticagrelor works by actually inhibiting the reuptake of adenosine. So it has nothing to do with the antiplatelet effect. This is a byproduct. So ticagrelor works on the P2 or an allosteric site of the P2Y12 receptor. But the side effect is that it blocks the reuptake of adenosine, and that's why we have higher levels of adenosine in patients that take ticagrelor. Well, why is that important? Well, if you remember in Plato trial, there was an increase or decreased risk of cardiovascular mortality. It's kind of interesting when you think of why that is. When you compare ticagrelor with adenosine, we know adenosine is a vasodilator. We know adenosine decreases ischemic reperfusion injury. We know it increases platelet inhibition. We know it decreases GFR, and we know the side effect of adenosine increases, the sense of dyspnea. These are all the same effects of ticagrelor. So some of the cardiovascular effects, the decrease of MACE with ticagrelor may be related to this vasodilatory effect. Hard to say. But we do know that you see with ticagrelor an increase in creatinine levels, about 10%. That's due to that decreased GFR. And you're all aware of the 10 to 15% risk of dyspnea in patients that take it. Okay, which of the following statements is false regarding platelet physiology? Platelet adhesions mediated by the von Willebrand factor. Platelet activation results from several agonists that bind to their respective membrane receptors on adherent platelets and release prepackaged granules of agonists. Platelets are nucleated cell fragments released in the blood from bone marrow megakaryocytes. Or platelet aggregation involves fibrinogen or von Willebrand factor binding to specific membrane receptors in the 2B3A. This is a wordy question, but if you know this, you know it right away. It's simple. Yeah, you got it. So platelets are anucleated. All the other stuff is garbage. Not garbage, but just to go through very quickly, or they're diverters. Those are questions that are going to, answers that are going to divert your attention away and confuse you and make you frustrated. But no, remember what you know. So the platelets are anucleated cells. They bind through the von Willebrand factor to an endothelial site of injury, and that's the platelet adhesion very quickly that induces a conformational change, which then expresses receptors, release of agonists through paracrine activity, and that in turn is your platelet activation, which then quickly leads to aggregation through cross-linking of fibrinogen. So a simple understanding of this pathology, the 3 steps of platelet aggregation or adhesion, activation, aggregation, and where we are with pharmacotherapy on inhibiting these. Most of our therapy is targeting here, old therapies here. We're starting to get into new antiplatelets that are preventing adhesion, so further upstream. Which of the following 2B3 inhibitors has the shortest half-life but longest duration of therapy? I guarantee you're going to get a 2B3A question. No one uses them anymore, we know it, but the writers love the pharmacotherapy, and it's probably would be a question like this. Anybody know this answer? Shortest half-life, longest duration. Exactly. That's going to be abciximab. So very simple chart to keep in your brain. Abciximab is a monoclonal large antibody. The eptifibatide and tyrifibran are small molecules. They have longer half-lives. The abciximab has a short half-life. Why is that important? If you have somebody with bleeding on abciximab, what do? You turn the drip off, okay? And you reverse the antiplatelet effect pretty quickly. Versus these, what do? You give platelets. You have to give platelets back. So that's the clinical vignette that might come up when older patient getting a 2B3A inhibitor. Question 5, which of the following drugs should have its dose adjusted in renal insufficiency? Argatroban, tyrifibran, abciximab, none of the above. Tyrifibran. That's a simple, you know it or you don't know it type of question. Tyrifibran is cleared by the kidney. Which of the following mechanisms leads to inhibition of platelet function following treatment with P2Y12 receptor inhibitors such as clopidogrel? So reduction in cyclic AMP, increase the VASP, which is the vasodilator stimulator phosphoprotein, inhibition of phospholipase C, inhibition of adenylate cyclase, or inhibition of C protein kinase. Tough question, but it goes into the pharmacology. So it's B. And this goes back to where the P2Y12 receptors act. They act at exactly the P2Y12 receptor, inducing a conformational change through G coupling, increasing cyclic AMP, thereby increasing the phosphorylation of VASP and decreasing platelet aggregation. So increase cyclic AMP, increase VASP. Number 7, which of the following best describes the reason prasugrel provides more potent and consistent platelet aggregation inhibition as compared to clopidogrel? It's absorbed over a barrier gastric pH range and is therefore less affected by proton pump inhibitors. The active metabolite is formed by a single oxidative step. The effect of foods such as grapefruit juice is lesser on prasugrel, or all the above. Someone said all the above? No. So this is getting to the pharmacology of prasugrel versus clopidogrel. It's really simple. The reason why prasugrel has its brand name Effient is it's more efficacious. That's how I always remembered that. It's a single oxidative step. It's not a prodrug. It goes right to active metabolite after one oxidation. Clopidogrel, on the other hand, undergoes oxidation and hydrolysis through a two-step process. And after metabolism of clopidogrel, of its prodrug, you're only left with 15% of the active drug. 85% of that active drug is going to be in the toilet. So it's very ineffective, but still good. We still use it. But that's why prasugrel has such a higher pharmacokinetic profile. Number 8. So Triton TIMI 38. We all know this trial compared prasugrel with clopidogrel among patients with an ACS and intending to undergo PCI. At 1 year, how did the occurrence of ischemic events and major non-coronary bypass bleeding events compare with prasugrel versus clopidogrel? Decrease, 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 no change, decrease, increase, increase, no change. C, excellent. Good job. So this is probably going to be on your boards. This was a landmark trial, TIMI 38, prasugrel versus clopidogrel in all comers of PCI and ACS. So those patients, I'm sorry, these are all ACS patients, non-STEMI and STEMI patients. So prasugrel had a significant decrease in the primary endpoint composite, but an increase in bleeds. Number 9, which of the following statements regarding prasugrel is false? It's a third-generation thienopyridine and it has more potent, consistent, rapid inhibition of P2Y12. In pre-specified subgroup analysis, treatment with prasugrel seemed to be less effective in subjects with diabetes compared to clopidogrel. It does not seem to be prone to alterations in pharmacokinetics, pharmacodynamics, or clinical efficacy on the basis of genotype. In the Triton 38 trial as a whole, those patients greater than 75, greater than 60 kilograms, or those with prior TIA or CVA benefited more with clopidogrel versus prasugrel. So which one of these are false? Pre-specified subgroup analysis, treatment with prasugrel seemed to be less effective. Okay, so this gets to patients with diabetes versus non-diabetes and these more potent antiplatelet. We know that the diabetic cohorts have a much more greater benefit than the non-diabetic cohorts with the same drug. So very, very important aspect. The subgroup analysis, though. We found the same data actually in those patients that received ticagrelor. So we saw it with prasugrel. Ticagrelor also, this is the platelet reactivity units, significant drop with both diabetics and that received ticagrelor versus non-diabetics. But the diabetics receive much more. Okay, cytochrome P450, 2C19, polymorphisms. So this gets to the genetics pre-testing or genetic profiling, pharmacogenetics in these antiplatelet agents. Basically, remember this with both Plato, which was ticagrelor, and prasugrel, which was Triton, which was prasugrel. The genetic, the effect of the antiplatelet did not have any effect on the gene, meaning if you were a loss of function gene carrier or not, i.e. 2C19, it didn't matter. The outcomes were the same. So that's why we say, theoretically, those patients that have a loss of function allele should just get higher, more potent antiplatelet than clopidogrel. Number 10, in the platelet inhibition and platelet outcomes Plato trial testing, ticagrelor was compared with clopidogrel among patients with ACS. How did ticagrelor affect the rates of mortality and non-CABG bleeding, major bleeding? Decrease, 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 increase, unchanged, increase, unchanged, 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 decrease. Even if you don't even read the question, just the answer confuses you. But try to focus, try to stay, understand what they're asking. What do you guys think? B, exactly. Decreased mortality, but like Plato, or like TIMI 38, increased non-CABG bleeding. And that's, you see here in this trial. Increased non-CABG bleeding here. Okay, number 11, polymorphisms. Which of the following genotypes can modulate intestinal absorption of several cardiac drugs? ABCB1, this is the multi-drug resistant protein, cytochrome P450, PIA and polymorphisms, or the VCOR, which is the vitamin K epoxide reductase. A. So these actually modulate intestinal uptake of a lot of cardiovascular drugs that we know. It's otherwise known as P-glycoprotein, otherwise known as multi-drug resistant protein. And it's expressed in the epithelium of the intestine, and it affects a lot of drugs, including the antiplatelet therapies. We don't test for P-glycoprotein, though. It never panned out clinically. But it could be on your boards. Okay, proton pump inhibitors such as omeprazole have been shown to reduce pharmacokinetic and pharmacodynamic effects of clopidogrel by modulating the effects of which of the following? 2B3A receptor expression, 2C19 activity, 3A4 enzyme activity, or P-glycoprotein. Yeah, this is a little bit of a gimme. Proton pump inhibitors, right? So B. The biggest one being omeprazole. What this does is it inhibits the 2C19. So very important. There is some effect on 3A4, but most of it's through 2C19. Okay, which of the following guideline recommendations has been given level for platelet function testing in clopidogrel treated patients? You're not going to get a question like this, but it's important to know this so you can answer questions that come about it. Someone said C. Exactly. It's 2B. There's very little data. In fact, at Sinai, we used to test, back in the days of Gravitas, before Gravitas came out, we would test antiplatelet activity, do PRUs on patients, and aspirin sensitivity, but we don't do it anymore. All of the cartridges are collecting dust. Every now and then, maybe we'll do it if we have an unexplained stent thrombosis. But by and large, these newer agents have just outdone all the testing. Okay, number 14. So this is a clinical vignette. 76-year-old diabetic, hypertension, smoking, intermittent chest pain. Vital signs are stable. No evidence of CHF. EKG with nonspecific changes. Elevated troponin. Renal and hepatic function normal. He's diagnosed with ACS and taken directly to the cath lab, which shows a large thrombotic OM1 with TIMI2 flow. So which of the following statements about this patient are false as it pertains to antiplatelet management? Personalized approach, genotyping to select antiplatelet therapy for patients with ACS may reduce ischemic and bleeding events. A strategy of guided de-escalation of antiplatelet treatment is non-inferior to standard treatment with prasugrel at 1 year. HPR, so high platelet reactivity on clopidogrel is associated with a higher risk of MACE post-PCI, whereas very low levels of on-clopidogrel platelet reactivity are associated with bleeding risks. Or post-PCI MACE rates are similar among clopidogrel-treated patients without 2C19 loss of function and prasugrel or ticagrelor-treated patients with 2C19 loss of function, or all the above. Again, a wordy question, I apologize, but the answer is D. So this was the PharmClo trial. This basically showed that in ACS patients, a pharmacogenetic response or approach actually had reduced endpoints compared to standard of care, just giving antiplatelet to anybody, any choice of antiplatelet, as opposed to personalizing the antiplatelet based on the gene. But it still doesn't pan out because most ACS patients we're treating with the higher intensity agents now anyway. I can't recall the last patient I treated with straight clopidogrel with an ACS. It's very rare. But it's important to understand the on-treatment platelet reactivity. So high treatment platelet reactivity, or HPR, increases your ischemic risk, and low HPR actually increases the bleeding risk. I would just know that, and I think you guys probably already do. Number 15, which of the following are true regarding platelet reactivity testing in routine clinical practice? The utility of testing has been validated. Patients with HPR have a higher event rate. Increasing clopidogrel dosing has been shown to reduce cardiovascular events. Switching from clopidogrel to prasugrel or ticagrelor has been shown to reduce cardiovascular events in HPR. B. So patients with high HPR have higher cardiovascular events. We know that. The problem is we don't know what therapy to give them to reduce it. And this has been shown in a number of trials. We see the signal, but we don't know how to reduce it. Those patients with a higher resistance, this first quartile, have much higher events at 6 months period compared to those patients with quote unquote no resistance, which is not a term we use anymore. There are multiple variables that lead to this platelet or high on treatment platelet reactivity. There's genetic factors. I wouldn't worry too much about these. Just the 2C19, the STAR2 allele, which is the loss of function allele. The STAR17 is the gain of function allele. This is the one that's going to have you a higher bleeding risk. Just know those two. There's non-genetic factors, and you know all these: age, gender, BMI, cardiogenic shock, and then some co-medications also increase bleeding or increase the HBR. Gravitas, this was a negative trial. This looked at antiplatelet treating or testing before going to the cath lab. Matt Price and his colleagues out in La Jolla, there was no difference. This was a negative trial and really pretty much put antiplatelet testing, PRU, to bed. 16, platelet aggregability is increased by numerous factors: thrombin, epinephrine, ADP, including hypertriglyceridemia. Elevation of which of the following lipoproteins is associated with reduced platelet aggregability? HDL, LDL, VLDL, lipoprotein A, or ApoE? HDL. So HDL has an interesting effect. All the other factors increase, but HDL can actually decrease your aggregation. An interesting fact. I doubt you'll get asked that. Okay, this is a question on de-escalation. So 76-year-old chest pain, abnormal stress test, mid-LAD stent. 1 week, developed shortness of breath. You think it's a result of ticagrelor, and you've discussed options for antiplatelet de-escalation therapy. Which de-escalation regimen is the most appropriate? So 1 week after receiving ticagrelor. So this is real life. You're gonna see this in practice a lot. 90 milligrams BID plus aspirin at this point, and you're gonna change. How are you gonna do it? Are you gonna stop? Wait, was this ticagrelor? No. So this should say ticagrelor, not prasugrel. Sorry. So stop ticagrelor, start clopidogrel. Stop ticagrelor, start clopidogrel 75. Stop ticagrelor, start 300 after 12 hours. Stop ticagrelor, start 600 after 12 hours. Stop ticagrelor and start clopidogrel 75 once daily after the last dose, 24 hours. Exactly, C. So you have to load. You have to load when you switch from ticagrelor. You're starting a new P2Y12 receptor inhibitor. You have to load it and just give it at the next time of the next dose. So very important. And this was actually a very nice trial done by Dominic Angelillo down in Florida, where you see the red line. This is your ticagrelor dose here in yellow. And you see the next lowest, even approaching that, would be 600 milligram load. And then eventually you get up to what would be your steady state. Versus all the other loading regimens are just going to give you higher platelet reactivity or lower platelet reactivity. Good. Okay, 66-year-old chest pain. Wait, did I go back? No, sorry. I gave you the answer. Okay, 66-year-old chest pain, abnormal stress, LAD stent, treated with aspirin, now prasugrel. So I mixed the answers up there. 3 months after PCI, developed bleeding, epistaxis. Which de-escalation regimen is the most important? So now you're going prasugrel to clopidogrel. So do you stop prasugrel, start clopidogrel 75, stop prasugrel, start 300 clopidogrel, stop prasugrel, start 600, stop prasugrel, start 75. You're going P2Y12 to P2Y12. Yeah, this is actually D. You're just going to load, you're already at a steady state of P2Y12 inhibition. And this is actually in the consensus guidelines of switching, international expert consensus on switching antiplatelet receptor antagonists. This is a really good article. If you guys don't have it, here's the citation. So when you go from clopidogrel or from prasugrel to clopidogrel, you're going to give clopidogrel 75 milligrams 24 hours after the last prasugrel dose. And it's really nice. You get both ways. You get all three agents and how to go in between each one. It's very, very valuable. Question 19, which of the following statements is false regarding treatment of unstable angina? The proportion of ACS patients worldwide who are managed medically without Revasc is about 40 to 60%. An early invasive strategy is indicated in initially stabilized unstable angina non-STEMI patients who have an elevated risk for clinical events. In unstable angina non-STEMI patients treated conservatively compared to clopidogrel, prasugrel significantly reduced the frequency of death from cardiovascular causes, MI, or stroke. Excellent. Good job. So this was trilogy ACS, no benefit with these higher dose antiplatelet agents like prasugrel in patients treated medically. Ticagrelor is different. There was benefit. Okay, question 20. I think this is close to my last one. In Champion Phoenix, IV ADP receptor blockade with Cangrelor, IV Cangrelor, had the following effect on stent thrombosis and severe bleeding, respectively, compared to clopidogrel. So stent thrombosis and bleeding. Increase, decrease, increase, no change, decrease, increase, decrease, no change, decrease, decrease. D. So decreased in stent thrombosis and minimal change in bleeding. And that's the Champion Phoenix trial. Rapid onset of antiplatelet activity the minute the IV hits the body, and the minute you turn it off, you get immediate rebound of your platelet reactivity or your antiplatelet activity. And that's it.
All right.
Yeah, a lot of questions and
Not basic scientists that what molecules are on.
yeah, clinical scenarios, but know your pharmacology. They do like a few questions on it. Either you know it or you don't. It's not going to be like a half-life, but it'll be a clinical vignette type. So, good luck.